Welcome to This Explainer. Today, we're putting on our detective hats to decode one of the absolute most common, yet kind of anxiety-inducing puzzles you're going to face in the emergency room: chest pain. Specifically, chest pain caused by pericarditis. I am super excited to walk you through this because we're going to break down the exact clinical logic you need. We're not just memorizing facts here, we're figuring out how to actually spot and treat this thing in the real world.
Here is our quick diagnostic roadmap for today. We'll start with the chest pain puzzle, unmask the underlying causes, gather our diagnostic evidence, go over the standard management and treatment, and finally, look at some really dangerous downstream complications.
Section 1. The chest pain puzzle. When a patient rolls in clutching their chest, what is the most likely diagnosis is literally the most critical question you have to ask. We have to rule out the immediate life-threatening suspects right away. It's kind of wild, but out of every 100 people showing up to the ER with chest pain, less than 10% are actually having a heart attack, and half of them have no cardiac disease at all. But hey, you still have to efficiently figure out exactly what's going wrong.
To solve this, we really have to contrast our main suspects, ischemia versus pericarditis. Ischemia, like a classic heart attack, is usually this dull, heavy squeezing or pressure. Honestly, it doesn't care if you take a deep breath, and it totally doesn't care if you sit up or lie down. The pain stays exactly the same. Pericarditis is completely different. It's an inflammation of the sac around the heart. Because it's inflamed, the pain is sharp. It's pleuritic, meaning it changes when you breathe, and it absolutely changes based on how the patient is positioned. Oh, and quick side note, while pericarditis can sometimes pop up after a heart attack, which we call Dressler syndrome, that usually happens several days later, not acutely in the moment.
Your absolute best clinical clue is how positional the pain is. It genuinely gets worse when the patient lies flat, and reliably gets better when they sit up or lean forward. This is probably because leaning forward changes the physical tension and stretch on that angry, inflamed pericardial sac. So if the pain changes with a deep breath, shifting around, or even pressing on the chest wall, you can usually cross acute ischemia right off your list.
And then you pull out your stethoscope. When you listen to the chest, you might hear the definitive smoking gun, a pericardial friction rub. It's this highly distinctive, triphasic, scratchy sound. Imagine two pieces of rough, stiff leather rubbing together every time the heart beats. If you hear that scratch, bingo, it points directly to pericarditis.
Section 2. Unmasking the underlying causes. So what's actually making that sac so inflamed? The truth is, the pericardium can get irritated by a massive variety of things. Viral infections are definitely the most common trigger overall, but the list goes on. Bacteria, like staph and strep, or even fungal agents can be the culprits. We also see autoimmune and connective tissue disorders causing a lot of trouble here. Systemic lupus erythematosus, or SLE, is the most common inflammatory cause, but rheumatoid arthritis and Wegener granulomatosis are totally on the table too. Plus, you have to keep chest trauma in the back of your mind, or even cancers, especially tumors from nearby organs, like lung cancer, physically invading that pericardial space.
But what happens when you run every test and nothing? You just can't find a clear cause. Well, in a lot of these so-called idiopathic cases, where the trigger is just a total mystery, the medical community typically presumes the culprit is a viral infection, specifically the Coxsackie B virus.
Section 3. Gathering diagnostic evidence.
The EKG is an absolute game changer here. It's considered the best initial and most accurate test for pericarditis. Looking at this readout, you can brilliantly see ST segment elevation across virtually all the leads, which makes total sense, right? The inflammation surrounds the entire heart, unlike a localized heart attack that only affects one specific area. But here's the real secret. Look for PR segment depression. While the ST elevation is super obvious, PR segment depression is the highly specific finding that absolutely locks in your diagnosis.
Now you might be thinking, what about a chest x-ray, since we order those for pretty much everyone with chest pain? Here's how you want to structure your thinking. While an EKG gives you the most accurate findings for the actual inflammation, a chest x-ray is mainly used to spot the underlying structural causes. A standard x-ray won't directly show you pericarditis, but it will definitely show you if the patient has pneumonia, or maybe a widened mediastinum from something terrifying like an aortic dissection.
Section 4. Management and standard treatment.
The treatment steps are beautifully simple and they just logically build on each other. Step 1, always treat the root cause if you manage to find it. Step 2, for all those presumed viral or idiopathic cases we talked about, you want to hit the inflammation hard with NSAIDs.
Step 3, and this is absolutely crucial, you always add colchicine. Why? Because colchicine has been proven to significantly drop the chances of this painful condition coming back.
Seriously, if you're gearing up for a medical board exam, or honestly, if you just want to practice gold standard evidence-based medicine, you need to cement this rule into your brain right now. NSAID plus colchicine is exactly the combination they want to see. It's the right answer every single time.
Section 5. Dangerous downstream complications.
Let's raise the stakes. If left unchecked, this can spiral into two major, very dangerous downstream complications: pericardial tamponade and constrictive pericarditis. Tamponade happens when fluid rapidly dumps into the pericardial sac and literally compresses the chambers of the heart. Since the right side of the heart has much thinner walls, it gets squished first. Constrictive pericarditis, on the other hand, is more of a chronic, slow-burning threat. Over time, all that inflammation leads to severe fibrosis and calcification. The sac basically turns into a rigid, bony cage that stops the heart from filling up with blood properly.
This scan is a perfect visual. It shows a massive pericardial effusion. You see that dark ring of fluid completely surrounding the lighter heart muscle? That is the exact kind of fluid buildup that leads to a life-threatening tamponade. Believe it or not, as little as 50 milliliters of fluid accumulating really fast can cause a tamponade. But if it builds up super slowly over weeks or months, that sac can stretch out and hold up to 2 liters of fluid. Either way, it squeezes the heart so tight that it simply can't pump.
Conversely, the chronic threat of constrictive pericarditis acts totally differently. Because the heart is trapped inside that rigid, calcified cage we mentioned, blood physically backs up. This presents with distinct, classic signs of right heart failure. We're talking edema, ascites, and a swollen, enlarged liver. You'll also see something called the Kussmaul sign, where the jugular neck veins actually bulge out further when the patient breathes in. And if you listen closely, you might hear unique diastolic knock, which is literally the sound of the filling heart violently slamming against that stiff, rock-hard pericardial wall.
So I'll leave you with this provocative thought to test your brand new detective skills. If a patient with presumed pericarditis suddenly develops perfectly clear lungs, low blood pressure, and bulging, distended neck veins, how quickly could you piece together those exact clues in a real-world, high-stress emergency? That specific triad points straight to tamponade, where immediate needle drainage is the only thing that's going to save their life. Keep that in mind the next time you face the chest pain puzzle. Thank you so much for joining me for this explainer, and keep learning.